Hello, sir.
So we usually start with the Ganti. Hello, everyone. This is Synergy Sunday session. Today is October 26th and a lovely day, fall day here. And today we have a very, very respected and honorable Dr. Adarsh Sharma here. So ये हमारे सीनियर भी हैं और मैं ज़्यादा नहीं बोलूँगी. आदर्श सर, सोनू has written introduction for you. एंड उसी की आवाज में मैं अभी शेयर करूंगी तो होपफुली इट वर्क्स सो लेट्स सी
Yeah, I can.
आवाज नहीं आ रही है।
I think you're mute. You're on mute, Shaya.
so we're going to try sharing one last time, otherwise I'll put the prompt of Adarsh's introduction and sorry about the glitch. So now let's see, I did turn the audio on, so let me know if it doesn't work.
From Dr. Ashok Bajpai, sir, as his guru from DTCT days of MGM MC to watching Ashiki movie 1990, 4 shows in a single day, matinee 3 to 6, 6 to 9, 9 to 12 with tiffin sharing, aloo paratha, with late Dr. Dinesh Oja, sir, at interval time, only one day before exams, to wooing Varsha madam off her feet. And by the way, impressing Lachu sir on Indore professor mentioned in Bailey and Love surgery textbook on his way to US of A. To a loving family, Ashu Mansi Raghav, to one of the top doctors and one of the top electrophysiologists for 10 years in a row in Chicago, the Windy City. All the way tickling the hearts in complex arrhythmias, sarcoidosis patients, substrate guided complex VT ablations, and EPS extraordinaire, to being a true friend, philosopher, and guide to one and all lives touched by Adarsh symbolizes him as a modern day Yug Purush, healing the broken hearts and broken world one day at a time. Tikkun Olam, repair the world. E pluribus unum, out of many one. Vasudhaiva Kutumbakam, world is one family. Adarsh sir is the original Ranchor Das, Shamlal Das, Chanchad Phunsuk Wangdu,
वो
aka
चंदन ने भेजा था
Ranchor
ज्वाइन
sir.
करके सुनो.
यहाँ अपना तुसी great ho, Jai ho, Jai ho, Jai ho. And by the way, Jai is also your future son-in-law. Wishing you and your family all the love, peace and bestest wishes for a fantastic future. क्योंकि जो चौका उड़ते हुए जाए उसे छक्का कहते हैं. पिक्चर अभी बाकी है मेरे दोस्त. टैली हो.
ये शायद
बढ़िया।
सोनू सर से शायद कुछ गड़बड़ हो गई है इसमें.
I hope it came through
नहीं,
because
yeah,
he
it
wrote it.
was very kind of him, but none of those, I don't deserve any of the elaborate things he
He
said, but
wrote it from his
best,
heart.
he
And
always does.
I'm going to share the script with everyone later. So anyone, if the audio didn't come through, you'll be able to read. It said everything that is apt to Adarsh sir besides his name, like Bharat also said.
बस हो गया, छाया हो
हमारे
गया,
हमारे आदर्श वाले आदर्श sir. So
नहीं
uh,
नहीं हो गया,
over to
छाया.
you. Over to you. All right.
All right. I think
Officially over to you.
no, I think, thank you for all the kind words. It's, an honor, privilege to connect with all the team, friends and family, not only here, but also in Indore. Thank you for giving me the opportunity, Chaya. So the idea is, can everybody see my slides?
Not yet. I think आपने
No, no.
share अभी
It's
शायद
not
से
showing. So let me just go back 1 second. Did I not share it?
हाँ maybe like I didn't share earlier audio.
Uh,
It's okay. I think
okay, let's see if I can share now. Can you see me
coming up,
in my space?
coming up.
Okay.
Yes. Now
All
we
right.
have. आदर्श
So
सर इन पर्सन ज्यादा करते हैं तो इसलिए we were just making sure.
no, no, that's okay. Yeah, I mean, I was just trying to get an idea about this, but you know, सोच रहे थे what topic should we talk on, and I thought, syncope may be a good topic to talk on because it is something that we often tend to take more casually. It's not something, it depends on the mood. आज कोई बेहोश हुआ तो कुछ नहीं करना. And some days we go about doing elaborate testing, despite the fact that there are so many protocols, guidelines written not only by the American societies, but the European societies also. We kind of become casual in our approach for syncope evaluation and management. And that was my thought that maybe we need to discuss this a little bit more because we can't be casual with syncope because at times syncope and sudden death are the same, except that in one you wake up. And that's been rightly said because it's important to differentiate. When you see somebody with syncope, the first thing that comes to your mind is let's try to risk stratify. Is it a low risk syncope or is it a high risk syncope? When we talk low risk syncope, it's your typical, most common vasovagal syncope that you see around. And it's okay to be casual with those once in a while because they have a low risk of mortality and morbidity. On the other hand, you do not want to be ignoring the cardiac causes of syncope because that may mean sudden death in the future. You may be lucky one time, but may not have an opportunity to evaluate and manage it the second time. So it becomes very important not to take syncope casually because syncope could be high risk too. So I know I'm going through my slides, but if any time it gets complicated or it's not coming out to your ease, please stop me. It's an informal discussion, as Chaya said. So we'll keep the question answers at the end, but I do not mind taking questions in the middle of the presentation too. So the way I wanted to do this today is, maybe divide it into three parts, talk about the etiology, prevalence, and more importantly, the definition of syncope. But then I also see how do we diagnose, how do we go about diagnosing it, and then if time permits, talk a little bit about the specific conditions and the treatment. So I think it is worth spending a few minutes in trying to define syncope because I think we lose it there. It is important to know what syncope is. It's not any loss of consciousness. It's a transient loss of consciousness that needs to be defined. And there are clear-cut definitions from the American Heart Association ACC-HRS guidelines. And what we have to know is that it is a symptom. It's actually not a diagnosis. Chaya, not to interrupt, is there a way I can get rid of these side and I can see my whole slides or no?
So
Hide
we
summary.
are not seeing the
You're
side
not
panel.
seeing that? Okay, I
We
got
see
it.
only
I was
slides.
just seeing it on my end.
Yeah.
So
That's for your
let's look
reference.
let's look at a few important words here in the definition of syncope. It's a symptom that presents with abrupt. The word is abrupt, so there's not much warning. Transient, complete loss of consciousness, inability to maintain postural tone, and rapid recovery, spontaneous. So if somebody is passed out and he's been laying there for half an hour and then he wakes up, that's not syncope because that was a long loss of consciousness. Many other times, it's like people fell and realized that, oh, I was found on the ground. How did that happen? Well, that may have been a syncope because by the time it's so short, by the time you realize you passed out or you fell down, you've woken up again. So the key words are transient, sudden loss, and spontaneous recovery. That's how you define syncope. Everything else can be a mimicker of syncope, but not syncope. And why that is important to know in the definition is because we treat things differently, whether it is syncope or a syncope mimic. So these are the common syncope mimics that we see around. We talked about somebody had acute alcohol intoxication and has been lying unconscious for a while and then wakes up, or somebody had a seizure when it's witnessed, it's easier to diagnose certain sleep disorders. Somebody has daytime sleeping because they have obstructive sleep apnea, not sleeping well at nighttime. The somatization disorders, हम लोग जैसे funked कहते थे, and I remember that, we were so bad. We used to give like chloramphenicol tablets under the tongue. I mean, whoa, I really regret doing those things, just trying to wake those patients up. But that's another thing where you think they're passed out, they're not responding, but that's not a true syncope because they didn't, spontaneously recover and it wasn't transient. Similarly, other things, trauma, head injury, hypoglycemia, एक थॉट रहता है कि कोई भी बेहोश हुआ सबसे पहले उसको शक्कर खिलाओ. We presume everybody is a diabetic, but the reality is more than sugar. It's the salt that's important. So syncope does have a significant impact in our managements, because if you look at it, uh, all of us, about 3% of individuals will have a syncope during their lifetime. And it gets more common as we get older. So almost 1 in 4 individuals as we get older may have a syncope. And it's not just that you'll have it one time. If you have had one episode, the likelihood of having a recurrence is about 35%, which is quite high. So it's important that, whether it's low risk or high risk, you identify and treat the syncope accordingly, because even if it's low risk, you could still injure yourself, break a bone, hurt your head. So it's important to be spending more time in trying to see if we can identify the cause so as to prevent the next one from not happening. 10% of the falls in the elderly are often due to syncope. We just feel ki, oh, gir gaye the, and he tripped, dhang se nahi chale. But the reality is, some of these are true syncopal episodes, and by the time they realize they're awake and they're on the floor, and they feel and they presume that, oh, I may have tripped, but they don't remember tripping. So history becomes really important in evaluating syncope. So it does also have significant impact on the quality of life. It does create a lot of stress, anxiety, depression, especially when you don't know the answers. Why did it happen? It alters daily activities, especially, if we have a strong family support, they become over supportive. They won't let you do various activities because, especially when the cause is not known. Okay, you can't do this, you can't do that. It alters daily activities, affects your quality of life, even restricted driving. There are also guidelines. If you don't have a definite cause, your driving should be restricted at least for 30 days. So it does impact in certain people, like if you're in a high risk profession, you fly an aircraft or a commercial driver, then it may also lead in change in employment. So syncope is just not something that individually is affected, but it affects the society as a whole. And that's why it's important to identify and treat it. But if you look at it, there's not much to syncope causes. Again, if you just put it in simplified ways, you have the neurally mediated syncope or the vasovagal syncope, the orthostatic hypotension, and the cardiac syncope. So three categories of those, you could say the orthostatic and vasovagal are the low risk ones, and the cardiac syncope is the higher risk one. And the key to all this, or the common pathway to all this, is a drop in blood pressure, drop in heart rate, decreased cerebral hyperperfusion that results in especially if you're standing up and gravity dependent in the neurally mediated and the orthostatic hypotension, this cerebral hypoperfusion results in syncope. As soon as you are on the ground, cerebral perfusion returns and you're back up, and that's why it's such a transient phenomena. The various causes, and we'll try to go over them in some detail, but not to an idea to not elaborate enough to confuse you all. But just briefly, we talked about, the neurally mediated. So when you say neurally mediated, it includes the vasovagal or the hypersensitive carotid sinus, situational, somebody's been coughing a lot, cough syncope, or has benign prostatic hypertrophy, has been straining a lot, or constipated in the bathroom, and they pass out. These are all what we call vasovagal or neurally mediated syncope. Then you have the orthostatic, which is more common in the elderly people, and many a times and more commonly brought on by certain drugs, certain new changes in drugs, especially strong vasodilators or diuretics that cause dehydration. And sometimes it's more challenging with the autonomic failure symptoms that may happen with diabetes or other Parkinson or other multisystem disorders. But the ones that we worry most about are the arrhythmias, because anything that's abrupt without warning, most likely it's an arrhythmia. And it could be both ways. It could be too slow a heart rate, which is the bradyarrhythmias, mostly a degenerative phenomena. And similarly, there is the tachyarrhythmias. Most of the time, it is ventricular arrhythmias, but sometimes SVT can also cause syncope in a situation where they have a strong, what we call vasodepressor response. And then you have another category of cardiac disorders where you could have obstructive disorders, brought on by, let's say, exertion for aortic stenosis or hypertrophic cardiomyopathy, or in some situations, not very common, but it does happen with pulmonary embolism and pulmonary hypertension. But what is important is that no matter how deep we dive in trying to identify these causes, one third of these remain unexplained. And those are the ones we worry about because we don't have a cause and this may come back again. And we have to be very careful in how to identify and diagnose those unexplained causes in one third. So, how do we diagnose? Now, let's start off first by saying how not to evaluate syncope. Now, we've seen there are so many algorithms around, but if somebody comes to you with syncope, कोई किताब खोल के तो बैठेंगे नहीं. We're not going to pull up algorithms and see कि कैसे manage करना है. But there are some things that, like I had said, it's the mood of the day how we manage syncope. We underdiagnose syncope, but at times we do over testing of syncope. कई बार होगा कि, okay, nothing needs to be done, but then we are doing a whole land of testing, which is unnecessary. So some of the testings which are not necessary, and I want to really stress on that because let's start off by saying that, let's understand syncope is not a neurological problem. So if somebody is presenting with syncope and you've defined syncope by the definition, transient, loss of consciousness, spontaneous recovery, it's vasovagal or other cause of syncope, but it is syncope. It's not a neurological problem. Do not start off by ordering CT scans, carotid Dopplers, EEG, psychiatric consultations. These are not necessary. In fact, if you look at the guidelines, they're in fact contraindicated. When we look at the guidelines and we go through class 1, 2, 3, where they're harmful or no benefit, carotid ultrasound, EEG, MRI, CT are all in the class 3 category, which is no benefit at all, because we are going in the wrong direction. We are not looking at the right direction of syncope. We're trying to treat or diagnose a neurological condition that doesn't exist. So the key thing is here, there are very few conditions where history is still important. And, as times evolve, as technology evolves, we've become more casual, in fact, careless in history taking and physical examination. We're relying more on ECG, echo, and more advanced testings that are out there. But syncope is one scenario where history is still the most important diagnostic tool. Physical examination may also be important at times, especially when you're thinking of orthostasis. Just checking a blood pressure sitting and standing gives you an answer that many other advanced testing won't give you. ECG, of course, is important. Again, the reality is if you've had a syncope and you do an ECG at that time, most of the ECGs will be normal, but there may be some situations where you can pick up or get some clues. It's all about finding clues that could have led to the circumstances to causing syncope. And then you have the monitoring, the Holter monitoring, and in the cardiac imaging, I would say echo. I normally like to stop right there because if you have to have a diagnosis of syncope, you'll get it with your history, physical, ECG, and monitoring and echocardiogram. Anything beyond that has a very low yield, and I'll show you that in just a second. So if you look at it just by history, physical, ECG, echo, you get about a 40% yield by this initial evaluation. The head up tilt, which is usually done for vasovagal syncope, is getting out of favor these days. And most of the information that you want from a tilt study can be obtained by a good history and physical examination. Everything else that we do, EP studies, stress testing, EEG, MRI, they really have a very low yield and is not routinely recommended unless we have certain situations that demand that these be looked into. The other thing that does have a yield is an implantable loop recorders, and I think we do not do too many of those in India, but it's something I'd like to share with you as we go through these slides in just a bit. So coming back to syncope and history taking, like I said, it's the most important diagnostic tool and also important in differentiating whether it's a low risk syncope or a high risk syncope. Because if you look at high risk syncope, they have a cardiac cause and they are the ones that we really worry about. On the other hand, it's not that we don't worry about the low risk syncope, but at least it helps us identifying based on history what you can tell the patient and the family. Well, this is something you had. I'm not sure why it happened, but I can tell you it's high risk or low risk. And just before we tell them, we need to know ourselves whether these are high risk or low risk. And that's how we look at these things. And this is a little busy slide, but I'll go through it. So you have an older male, the likelihood of this being a cardiac cause of syncope is high. Now, especially if this is the first time it's happened to somebody. It doesn't mean that you can't get a vasovagal syncope in an elderly individual, but if you do, they usually follow a bimodal pattern. So the first thing I usually ask them is, have you fainted in your childhood years, in your school days, in your college days? If the answer is yes, then there is a chance that they could still have vasovagal. But it's very unlikely to have a first vasovagal episode at an age greater than 60. Now, if you've had any kind of structural heart disease known, CAD, heart failure, previous arrhythmia, automatically it becomes high risk. If you have a very brief prodrome, like brief palpitations, and then the episode is very abrupt without warning, again, high risk. If it happens during exertion, high risk. If it's in supine position, it's high risk because most of the vasovagal and the orthostasis are position dependent. In other words, that they're happening when you're standing up or you're sitting. They don't usually happen when you're in the supine position because they're gravity dependent. So if it's happening in the supine position and you're getting a syncope, automatically it tells me it's high risk. And in my definition, it would be an arrhythmic, not even an obstructive structural cardiac disease because it's happening at rest in supine position. So supine position arrhythmia, syncope, in my mind, is either a bradyarrhythmia or a fatal tachycardia arrhythmia. Low number of episodes, you find some abnormalities in cardiac exam, slow heart rate, fast heart rate, abnormal murmurs, or if you have a strong family history of sudden death. So I said older individuals usually have cardiac syncope, but even in younger individuals, if somebody has a strong family history, there may be certain genetic syndromes also that can predispose you to being or having a high risk, and those need to be evaluated as we'll go through it. However, on the other hand, the non-cardiac causes of the syncope that we typically discuss under the two categories of vasovagal being the most common and orthostasis being the other. Vasovagal tends to occur more in the younger age. They have definite triggers, prolonged standing, after anxiety when they're fearful in a dentist office, pain, blood draw. Those are situations we've all come across, and we've seen how even in our medical school days, we've seen how, when blood draws were being done, some of our colleagues would just pass out. Those are all situational or vasovagal syncope. Standing position, we talked about it already. If they have prodrome, and again, they have a little bit more prodrome as opposed to the arrhythmias, meaning typically nausea, vomiting, feeling warm, queasiness in the stomach, things like that. We talked about specific triggers and situations, cough. And another thing that if they're happening frequently, then they are probably low risk, even though you've not identified the cause. Because, if it's a high risk situation or a high risk cause, you're not going to have multiple episodes. You may have one and the next one may be fatal. So if you've been having syncope since your younger years, multiple episodes, once every few months, you're most likely dealing with the vasovagal syncope. So again, I know I went over this a little bit more in detail, but also in a rush. but it's the most important part in trying to identify syncope cause and risk stratifying it between low risk and high risk. When you check, we're checking, moving on from history to physical examination. And I think checking the blood pressure is the most important thing here and looking for orthostasis, specifically in the elderly people. And although we will have the patient stand up and check the blood pressure, give it a 30 seconds at least wait, if not 3 minutes, because everybody's blood pressure tends to go down when they stand up abruptly and then it stabilizes. And that's not true orthostasis. You need to see a drop in 20 millimeter of mercury, which persists for up to 3 minutes duration. So check it at least 30 seconds after standing, not just right away.
Others,
The
so
next thing,
just
of course,
going back to that
yeah,
slide. So was
yeah,
that showing the first picture, the
is
dizziness
yeah.
happened
So
right
the
away?
first picture it shows right away and then it stabilizes as somebody
Okay.
just stands up. So this is a normal response you may
Okay.
see.
Got
On
it.
the other hand, this is a more persistent response that you see when they're standing up. So a drop in the blood pressure and a
Okay.
drop of a systolic blood pressure of 20 millimeter or a diastolic of 10. And these are usually associated sometimes with increase in heart rate, sometimes if they have other autonomic dysfunction features, may not. Chaya, let me know on the time front. Okay, I can just speed things up. So ECG again, most of the time, like I said, we really don't have much of a clue on a resting ECG, which is done in a 6 seconds duration. But at times you may, like on the second, on this slide, you see an AV block that's happening, a Mobis type 1 AV block. This is not enough to cause him to pass out, but it tells us that if you see something like this when he passed out, he was probably in complete heart block at that time. Or if somebody has a structural heart disease, by history and is having these runs of non-sustained ventricular tachycardia, then it tells you that these ventricular arrhythmias could have played a role in his event of syncope. This is another slide in a younger individual when we always try to blame them as vasovagal. They also have genetic syndromes or other abnormalities or electrical disturbances. This is a patient with the WPW syndrome, and everybody who's done medicine is probably aware of this beautiful ECG where you see a short PR interval and the delta wave. So I'm going to skip tilt table study. This is a protocol that was being done in diagnosing vasovagal syncopes, but falling out of favor now. But the carotid sinus massage still remains. And it's important because we tend to ignore this in our elderly population. About 10% of our patients who fall in the elderly age actually have a hypersensitive carotid sinus sensitivity. And you can do a bedside testing of this. And if they're hooked up to the telemetry or a monitor, you can see with gentle pressure, you can get a pause of greater than 3 seconds duration. And this is very positive for a hypersensitive carotid sinus. Um, like I said, this is a common presentation in the elderly people, and you will sometimes it happens like you're wearing a tight collar and you're passing out, and again the same scenario, or you're shaving and you're passing out. So evaluate carotid sinus hypersensitivity in the elderly, especially with those who have been having frequent falls. So we've done history physical, we've done basic ECG, and then the other tool that I feel is really important is an echocardiogram, because in echocardiogram, many times you may not have had any history of cardiac disorders, but they get picked up for the first time, like a dilated left ventricle, especially if it comes on gradually in a patient with myocardial disease for various reasons, most common being, of course, the non-ischemic dilated cardiomyopathies, which may have had subtle myocarditis in the past. You see a dilated left ventricle on the left one. Or sometimes they have had old MIs and you're known to have history of coronary artery disease. So you see an enlarged heart, a weak heart, they're prone for ventricular arrhythmias and sudden death. This is another example where you see a very thick septum in hypertrophic cardiomyopathy. And that's why it's not based on history, it's not unusually uncommon to be ordering echocardiograms, because at times you may pick up genetic syndromes that you have not been considering. But I usually like to stop at the echo, and doing any more testing beyond that provides very little information. Um, we sometimes think, well, he had syncope. Everything we try to relate is to coronary artery disease. The reality is, ischemia as a cause of syncope is extremely rare. And they've looked at these studies where they've done stress tests in these patients, and the yield is extremely low. And even if you have some CAD, it's not the cause of your syncope, it's just an incidental finding. So we normally do not recommend a stress testing unless there's a good reason. If the patient said, "Oh, I was having chest pain before I passed out." The only situation where you could pass out because of a coronary event is if you're having ST elevation MI, and that too, or a severe ischemia, and that too, it's not the ischemia that's causing it, it's the resulting ventricular arrhythmias that happen, or the AV blocks that happen result of the MI that can cause you to have a syncopal episode. But ischemia per se is not a cause of syncope, or an extremely rare cause, and therefore not routinely recommended to get a stress testing unless your history tells you otherwise. Uh, Now, sometimes stress testing can be useful. And when I say stress testing, purely based on exercise stress testing, if they give you a history that the syncope occurs with exercise, because you can have exercise-induced AV block, as you see here on the left one. And this exercise-induced AV block is usually a marker of significant infra-His conduction disease. Sometimes could be degenerative, sometimes could be picked up in conditions like sarcoidosis. In other situations, you could be having exercise-induced ventricular tachycardia, as you see in this screen and this. Now, not all ventricular tachycardias are bad. Some are idiopathic. And it's important to diagnose this so that they can be treated and cured by catheter ablation and would not need to be at a risk for these ventricular arrhythmias or recurrence of syncope going forward. There's other genetic syndromes which we call CPVT that can sometimes be brought on by exercise, and you can see multifocal PVCs here. So the key word here is, if your syncope is with exercise, get a stress test, and that too exercise-based, not a resting thallium or myocardial perfusion. But if it is not related to exercise, then a routine stress test is not necessary. Sometimes you will have anomalous coronary anatomy in the younger individuals. Again, you'll have clinical history of chest pain and all that can cause it, but that doesn't mean a routine angiogram is needed in all patients with syncope, or a CT angiogram for that matter. EP study is also probably even less recommended. The only time we would do an EP study is if a patient is already known to have a structural heart disease. When I say structural heart disease, I mean heart failure, low EF, coronary artery disease. Now, when you have LV dysfunction, it's obvious on your echo, but when you have coronary artery disease with patients with normal EF, these are also in the structural category. And if I have to say one category where I really like to do an EP study in syncope patients, is CAD patients with normal LV function. EP study has much less role in assessing bradyarrhythmias than it is for ventricular arrhythmias or other tachyarrhythmias like SVT. So when we have no options, like I said, 1/3 of these diagnosis of syncope is unexplained, and we don't have a definitive diagnosis, we go to the monitoring systems. And you're all familiar with, Holter monitors and MCOT monitors or event monitors, but they have a definite role. You can only do it for 2 days, 14 days. MCOT or the event monitors, you can do it up to 30 days. What is the likelihood you're going to have another syncope in 30 days? Very low. So you do a testing of these kind and your monitors come back normal and you say sub-TK, everything is good. It's not sub-TK, it's just that you didn't have a syncope episode, so we didn't catch it. It's not that everything is normal, you didn't catch it. So therefore, the role of these implantable loop recorders, which are like small devices that can record up to 5 years duration. These are really small. Now just going to just move on to this. So this is the size of what a loop recorder looks like. And these are implanted parasternally, left parasternally, equivalent to where your lead V1 or V2 would, or actually V2 or V3 lead would be. And these continuously monitor. And I know there are limitations in India for remote monitoring, but here in US, these people are monitored not only at the time of an event when we can go back and check what really happened at that time, but also it is being continuously monitored from home, from the devices, from the smartphones, so that anytime you have any bradyarrhythmias, because the key is the actually the proof is in knowing what happened at that very time. So you have to play like a detective, and by the time somebody comes back and is recovered from syncope, everything looks normal and you really feel, oh, everything is good. But when you have one of these loop recorders and you have another episode of syncope, it can tell you exactly what happened at that time. And even if you don't have remote monitoring, it can go back. You can check the device just like you do a pacemaker check. And you can check the device and tell us, well, what happened at 10 a.m. when he passed out, and it will tell you what happened. And that helps us in diagnosis. Most of these, if you look at it in reality, a lot of these patients have actually bradyarrhythmias as a more common cause when the data on loop recorders have been followed. But sometimes you're surprised with other causes, and sometimes patients are just having, autonomic dysfunction and no arrhythmias. So it helps us in defining the causes of unexplained syncope. So do I have a little more time, or Chaya, should I stop and wait for questions here, or do I go into a little bit
I
more
think we
detail?
should go through the management a little bit, maybe
Okay.
another 5 minutes.
Okay, so we'll try to go through this real quickly.
Sure.
So we will first talk about the two, so I won't call them low risk completely, but the so-called relatively low risk. When we talked about syncope, we talked about orthostatic hypotension, vasovagal, and then the cardiac causes. So let's do the orthostatic hypotension. And this is easy to know just by history and by physical examination, like we said, looking at the orthostasis. The etiology, again, this is something more common in the elderly than in the young. So when you have your elderly patients come in with this, it will never be a one-time thing. Most of the times it will be more than one episode, or they've been having warning signs like postural dizziness. In the elderly, drug induced is not uncommon, or in fact, I should say they're very common. You're on strong vasodilators, you're on doxazosine or one of those for your prostate, or you're on a strong vasodilator like hydralazine for hypertension, or you've recently been started on some diuretics. I'm not a very big fan, although the guidelines say hydrochlorothiazide in the elderly for hypertension, first line management. I'm not a real fan in the elderly for hydrochlorothiazides. I have seen so many syncopal patients in the elderly just by hydrochlorothiazide. So be very careful, and just altering these medications and asking a history if these were recently initiated helps us in identifying the cause. What gets more difficult and challenging orthostatic hypertension is the secondary causes, which are related to diabetes, amyloid, which is involving the autonomic nervous system, or those which have multisystem atrophy and Parkinson disease. Those are chronic problems. You have a partial dizziness, multiple hospitalization, multiple syncopal episodes, and can be tricky to treat. So this is just a quick algorithm of how do we manage it. Again, drugs is easy. If somebody's had dehydration from GI upset, it's easy. Increase fluid intake, salt. Again, for these, salt is the key, not blood sugar or giving them sugar. But if it's a neurogenic orthostatic hypotension, which is the more complicated one, whether it's Parkinson, multisystem, diabetic autonomic neuropathy, water ingestion is still important sometimes, because hypovolemia is always a trigger. Sometimes patients have to be admitted and given normal saline in the hospital. But then there are other things that we just go, when you have multiple options, it just tells us we don't know how well to manage them. So we throw out so many options like thoda ye kar lo, thoda wo kar lo. And that's how it is for orthostatic hypertension, which are neurogenic in origin. So when we talk about compression garments, we say, stockings, compression stockings. One thing that you have to realize is, if you have to use compression stockings, which work a little bit, not too much, you have to have them at least thigh high. If you're doing a compression stocking or sif calf tak hai, it is of no use. It has to be a minimum of thigh high, sometimes even up to the abdomen. Counter pressure maneuver, I'll show you a picture of that in a second. Midodrine is the most effective medicine. It's a vasoconstrictor, constricts both the veins and the arteries, raises your blood pressure, and it's the most effective for orthostatic hypotension. But Becomes challenging when you have, supine hypertension and also associated with it. Droxydropa is another medicine that is specific for neurogenic orthostatic hypertension. Fludrocortisone acts by retaining salt and water. The thing that becomes challenging in our elderly patients is they also have many of them have hypertension, and then they have hypotension or orthostatic. I usually tend to say keep their resting blood pressures higher. Don't be aggressive with treating their blood pressure. So leave the resting blood pressures in the 150 range. One other couple of other medicines that can be used in these refractory syncopal episodes are octreotide, which blocks this. It's a somatostatin analog, blocks these splanchnic vasodilatation and helps, especially in those who have syncope after meals. And pyridostigmine is another one which I find useful in our patients where it's difficult to treat because they have a hypertension, which is also equally difficult to treat. So most of these will increase the blood pressure, but pyridostigmine won't. So if you have a patient who you've gone through everything and nothing is working, um, give a try of pyridostigmine. The vasovagal or the neurally mediated, again, are the most common. We talked about it, various scenarios. It's a complex syncope algorithm or a reflex, and there's so many mechanical receptors, so many triggers that initiated reflexes between the brain, the medulla, the vagus nerves, and the end result is basically results in vasodilatation at the lower limbs, which drops the blood pressure, and a bradycardia, which results in a combination. And there are various combinations of drop in blood pressure and bradycardia that result in syncopal episodes. So options again, salt and intake, but when vasovagal keeps recurring, same that we talked about orthostasis, we talk the same kind of medications here. Now, it's easier to treat vasovagal because unlike orthostatic hypertension, because many of these patients are younger and do not have resting hypertension, so using midodrine is quite effective. This is the only class 2A medication. If it's a very young person, sometimes fludrocortisone helps because it's salt and water retention. Beta blockers, although there have been some studies to say that it's really not proven in future studies, so I hardly ever use beta blockers. Sorry? No. Orthostatic training, there are some serotonin inhibitors. How well they work, well, very fair. And in rare situations, if you have a cardioinhibitory type of a response, meaning the vasovagal is predominantly related to bradycardia rather than drop in blood pressure, rarely people will give pacemakers. And I'm hesitant to give any pacemaker in the young, but if it's the elderly, my hesitation is probably less. We'll just skip through this. This is just something I was saying, both for orthostasis, hypertension, and vasovagal. There's some certain physical maneuvers because they give you some warning. And even if it gives you a warning before you pass out, let's say you're driving, you can pull over. If you're standing, you can sit down. These are certain maneuvers that can help prevent these reflex or orthostatic faints. So if you're standing, cross your legs like that, or use a ball. And what these hand grip tilting and all do is they increase your vascular resistance and increase your blood pressure, or pulling through your hands like this, it can help avoid the abrupt syncope and give you some time to at least sit down or lay down and avoid you from getting hurt. Well, there's a lot about yoga, and I think, we could have another session on yoga and vasovagal syncope, but there is a lot of interest in yoga also as an adjunct therapy. And then there is role of some emerging role of ablation of the vagal nerves or the ganglions in the left atrium and the right atrium, which is an evolving thing, especially in the younger people, where we do not want to give them pacemakers and they have failed multiple medications and attempts, and the episodes keep recurring. So there is a role that we will hear about more in the future. We've been doing a few of those, and I would say the success is modest. We need more long-term results. So moving on from the low risk relatively ones to the more higher risk ones, like I had told, when we don't have a cause and we try to put a loop recorder to define what the cause could have been, the loop recorder data and studies have shown that bradyarrhythmias are probably the most common cause of unexplained syncope, especially in our elderly population. And that could be because of intermittent sinus node dysfunction. You do an ECG looks good, but the intermittent sinus node dysfunction. So when they're fainting, they may have bradyarrhythmia. Same goes for second degree, third degree AV block. You may get a clue if the patient has other conduction abnormalities like a left bundle branch block or a bifascicular block, that they are more likely to have AV blocks. But again, sometimes those clues are not there. So if you have proven to have bradyarrhythmia as a cause, pacemaker is the definitive treatment for it. No medication helps. You have the conventional transvenous pacemakers. We've moved on to something we call a more left bundle branch area pacing, which creates more synchrony in the heart. Maybe some other day we'll talk about it. Some of our patients are high risk for pacemakers because they have recurrent infections or they don't have vascular access, like the dialysis patients. In those scenarios, what is emerging is the role of what we call leadless pacemakers. These don't have any wires in place. The risk of infection is low. They don't need vascular access. We go through the femoral veins and implant them like a bullet in the trabeculae on the muscle of the right ventricle. So other causes of the arrhythmias are the tachyarrhythmias. Supraventricular arrhythmias, if you see as a cause of a syncope, send them directly for an ablation, because there are very few things in our science which are curative. SVTs are curative. You have high blood pressure, you're stuck on two medicines. CAD, we give you some other medicines. We suppress them, we control them, we can't cure them. SVTs are one arrhythmias that are totally curable, with a success of more than 90-95%. So anybody who has an SVT and syncope, definitely as a first-line therapy, send them for an ablation. If you have ventricular arrhythmias, some of those that are low risk can still go for an ablation and be curative, but those that are higher risk, they definitely need a defibrillator. And that's where we come to the highest risk possible is the patients with syncope and patients who have coronary artery disease, because these are the patients where we think syncope is sudden death and you just woke up. So if you see a patient with syncope and has coronary artery disease, as we know based on guidelines on who gets a defibrillator, if you have a low ejection fraction, if it's less than 35%, automatically there's no further testing needed. You need a defibrillator to keep yourself proven, because even if you didn't see ventricular arrhythmias, the likelihood that this syncope was because of ventricular arrhythmias is extremely high. Where it gets a little tricky is your EF is normal, but you have coronary artery disease. So that's one scenario where I had previously talked about, where an EP study may be utilized or may be useful. So if your ejection fraction is more than 35% or in the normal range, you do an EP study. And during an EP study, if you're inducible for ventricular arrhythmias, it again tells you the subset of patients who are highest risk, and these are the patients who should get a defibrillator. Where we don't have a definite etiology, they can get a loop recorder or a cardiac implantable monitor. Now, it's a little different in non-ischemic patients, because when we talk about EP study having a role in coronary artery disease, it's non-predictive in patients with non-ischemic cardiomyopathy. In other words, if you do an EP study and it's positive, it doesn't tell you much. If it's negative, it doesn't tell you much. So if you have a patient who has non-ischemic cardiomyopathy and comes in with a syncope, regardless of what you think, oh, this may have been just because of a change in medicine or orthostasis, their mortality is really high. It's about 45% 1-year risk. So these are the patients that should get an ICD just based on syncope with no additional testing. So other genetics channelopathies, we'll skip through those in interest of time. Neurology, like I told you, is not a usual manifestation. So don't waste your time in doing neurological evaluation. If there is a mimicker of syncope among the neurological disorders, it's seizure. And, most of the times if you have a witness event, you would be able to differentiate that too, although sometimes EEGs and all are also needed. But for the bigger picture, do not think syncope as a neurological problem, and do not go on the path of doing carotids and CT scans and so forth. So I'll just conclude here by saying that there are many causes of syncope. It's a common symptom with many causes. History and ECG are the most important initial diagnostic test. And it's also important because it differentiates the high risk and low risk conditions. You do not want to miss a high risk condition because it could mean fatal death the next time. Hospitalizations may not be necessary for all patients, but yes, evaluation is needed. Neurology evaluation is rarely helpful, so avoid unnecessary diagnostic testing. One third of the cases may remain undiagnosed, and this is where the role of the implantable cardiac monitors come into play with unexplained syncope, because they have a yield about 40-50%, and these can be monitored up to 5 years in duration. So it's not something that can be, because you may not have your second episode of syncope for a year or two or even longer. And the best guidelines come from European and the American Heart guidelines. If you want to go through those and look and see how to manage and evaluate syncope. So I know it was a little rush, it was a little bit of everything in here, but I hope I was able to at least give you some basics on how to evaluate and manage syncope. And I thank you all for the attention, and we'll be happy to answer any question based on how much time Chaya has for us.
Thank you so much, Adarsh sir. That was excellent. Actually, मेरे लिए तो बहुत ही useful था because I am very out of touch. So I'll let the cardiologist ask questions first, and then I have a couple of like lay physician, primary physician questions.
Okay, so yes, Dr. Adarsh, मैं तो ना मतलब सुना भी मैंने और आपको देखा भी और आपके सुनने की स्टाइल को भी एंजॉय किया.
आपको तो सब मालूम है, आप मत पूछो
नहीं नहीं नहीं
क्वेश्चन,
नहीं नहीं,
आपको
आई एम
सब
कमिंग टू
मालूम है।
दैट. सो आई एम कमिंग टू दैट. सो मुझे जो चीज नहीं पता थी वो यू विल बी सरप्राइज, यू माइट बी सरप्राइज कि ये चीज भरत को क्यों नहीं पता थी. बट आई डिडंट नो द मैनर्स दैट यू टॉट. आई वुड टेल एवरी पेशेंट मूव एंकल्स, दैट्स ऑल. Just heels up, toes up, heels up, toes up, heels up, toes up. Do it many times before you get up, and from toilet seat or bed to toilet in the midnight, or after lunch or dinner from the dining table. Just toes up, heel up, and do it 5-7 times, and then do it. So postural hypotension as well as possibility of even vasovagal, I thought. But then the pictures that you showed me, I mean, that's so I will use them now. So yeah, one was this. Second was you are holding an object tight, and third was you are standing with the crossed legs.
So ये हाथ जो हैं ऐसे करके and then pulling on it, and that helps. Now these are all useful more for vasovagal, but जो orthostatic वाले हैं, those are the more challenging to treat, because these are useful because you're having your vasovagal once in a while and you're driving or you're something, you can pull over or sit down and do these maneuvers and get them over with. But the challenging ones, which I didn't have too much time to go over, is for the orthostatic, because those are the really difficult ones to treat, because even if they don't have syncope, तो उसमें दो चार चीजें जो important हैं also in exercises for both vasovagal and orthostatic is building up calf muscle. जैसे आपने बोला ना, that's really important जो आप करते हो, that's a great maneuver. But some of the exercises that you want to tell them to also do is stationary bikes, rowing. Those are two exercises that are very helpful. And if somebody can swim, that's another thing. So those are things that help build it up. The last thing that is, there's something called orthostatic training. And we've seen that to be useful. I have personally found it to be useful. Some studies actually say in the long run, it's even better than all the medications and all the other maneuvers combined. This is called orthostatic training. So it's a simple thing. I don't know if I can show it to you. But we basically, let's say we stand straight against the wall with our shoulders hitting the wall, but not our butt. So it's like an 80-degree incline. तो सिर्फ दीवार पे सिर्फ shoulders हैं और आप ऐसे खड़े. So it's basically kind of training you with a chair by your side. I usually tell them start with 5 minutes, 10 minutes, build it up. I'd say get your favorite TV channel on the screen, because ऐसे बोलोगे खड़े रहो तो you can't. So you just stand with this at a 70-80-degree incline, chair on the side. If you get dizzy, sit down, and do it multiple times a day. It's a long process. It doesn't give immediate, satisfaction, But I'll tell you, even in my experience, those patients who have had, I call them obedient patients, they have had a lot of benefit with this. It's called orthostatic.
Lovely. And then you told emphatically that the compression stocking should be thigh high
Minimum.
for these patients. Yeah, that's
Because
also very
otherwise
important.
it's
Yeah.
a placebo. It's a placebo.
Another thing I thoroughly enjoyed for everybody else is the fact that he said, somebody who has got the first episode after the age of 60, you got to be very careful before you label it as a mild or benign type of syncope. Because this is like a kind of tendency if it was vasovagal. So they should
Right.
be able to recall कि हाँ मैं assembly के अंदर गिर गया था एक बार
Huh.
फिर जूता सूंघा हो प्याज सूंघा हो but it was actually vasovagal. Yeah.
The
Yeah.
first question I ask my syncopal patients who are above 60 is, did you ever faint in your younger years?
Yeah.
Because then
Yeah.
my thought process will change to other things. But if it didn't, because you can have syncope in the elderly, but they've usually had some, it's a bimodal pattern. It happens in the young teens, goes away in middle age, and comes back in later years. But it's very rare to have it first in the later years.
And what about, the elderly people who are going into toilet and fainting there and also after binge drinking?
Yeah. So those are again, those are what we call situational syncope. It's like one of the hardest ones for me to treat are some COPD patients who just cough and pass out. And there is like nothing you can do about those. So sometimes again, this is not a part of any guideline. And there are people who will still go ahead and give pacemakers to them. I think it's too much of a deal to give them pacemakers because you don't know. Some of it may not be a bradycardic response. It may be a hypotensive response. And you do a pacer and it's not going to change. So one thing that I have found useful, especially in the coughing syncope, is going back and giving theophylline. Theophylline increases your sinus node, it acts through the adenosine receptors, and it can overcome some of it. So that's the only medicine I've found for cough
And
syncopes.
it might also reduce cough, it was
Yeah,
UPD.
yeah,
And the barber thing, there's somebody
yeah.
who's shaving you and
Because
uh,
you initiate the hypersensitive carotid
yeah.
sinus, and or I can't tell you how many times it is in the elderly, they keep coming to the hospital with recurrent falls. अगर आप उनसे बैठ के सोचो कि did you trip? No, because if you're falling, you will know you're falling, right? कि पाँव गलत आ गया, कारपेट पे आ गया, सीढ़ी गलत चली
Yes,
गई.
yes,
But if you
yes.
the first thing
Yeah,
is, no, I don't remember, but I was on the
yeah,
floor, so I probably tripped. So
yeah.
then that is not a fall. That's a syncope.
Thank you from my side, sir. Lovely,
Thank you.
absolutely lovely. And thanks, Chaya, to get Adarsh, sir. जैसे सोनू सर ने कहा था कि there is another aspect also, so maybe we should reinvite him for something other than arrhythmia, मतलब arrhythmia of life, how to handle arrhythmias of life and not of heart. Some other
You
day,
know, I,
maybe we
I,
should also
you know,
discuss.
I strongly believe on that different note, I strongly believe that the era has come that all of us as doctors also have to be psychiatrists because our patients, especially as they get older, they need more psychological hand holding also to make them, ease their condition. So these days I've become a psychiatrist also for most of my patients.
तो छाया भी
Yeah.
यही कर रही है. छाया is learning more of psychiatry and psychology than pediatrics. I think she's taking.
Yeah, learning the communication skills and also relating to the patients. But others sir नीता भी है. I will related to what you were asking about barber. हम लोग बच्चों में देखते हैं कि बाल बनाते हुए सिंकपी हो जाती है जब एकदम से जोर से बाल बनाते हैं ब्रश करते हैं. तो और then you said with deglutition,
Degglutination.
defecation, micturition तो उसको मैनेज कैसे करते हैं when
So
it's
again,
every
these
day
are
like
these are difficult things. They're all behavior modification. So the bal jo aapne kiya, that is pain. So there's so many triggers to it. It's like um, pain is one, anxiety is the other, prolonged standing triggers like dentist appointment में कई बार होता है, blood draw में होता है. तो just to say कि चलो सबको midodrine increase कर दो doesn't help. I don't like to start off with medication. So even in for vasovagal, the if it is situational, there is a trigger, then you have to avoid behavior changes. So you have to comb differently, or if somebody is having deglutination, then smaller meals, avoidance of bigger substances, थोड़ा
That's like
jello या जो भी.
biofeedback or something like that.
Biofeedback helps. There has been some yoga effects to it. But
Hmm.
in a typical, if because these situationals have to be treated by behavior modifications
Hmm.
or by altering the situations. जो true vasovagal हैं, जैसे ये नहीं कि cough से हुआ या pain से हुआ या blood draw
Hmm.
से हुआ, उसमें salt and hydration is the clear thing. And I didn't
Hmm.
go into this in detail, but at least having 8 to 10 liters, 8 to 10 glasses of fluid, and at least two spoons of salt a day is important.
Okay.
So, they are more effective than any medicine. So, increasing your salt intake, some people who can't take salt, we also have salt tablets for it. But,
Sure.
कम से कम 2-2.5 liter fluid on a daily basis is
Hmm.
important. And that fluid, because just fluid in itself is not important. You take fluid without salt, you're going to pee it all out. So you need salt to
Hmm.
retain that fluid.
Hmm.
At the same time, you don't want fluids to have any caffeine-based things because you're going to lose all that. So it has to be salt based with fluid retention. Then only the fluid is retained when you have salt in your body. Sometimes I tell people pretzel cow, chips cow, especially the
Hmm.
younger people who have vasovagal, just increase your salt
Hmm.
intake. That way,
Right. Right.
some
They'll be
people have.
happy. They'll be
Yeah.
happy. Processed food and canned food. But Anjeev, you have unmuted, and I'm sure he's a neurosurgeon, so he has
आदर्श सर नमस्कार। मैं भोपाल में
Namaskar.
हूँ, एनजीओ
Oh,
चौरसिया,
nice.
भोपाल में न्यूरो सर्जन हूँ मैं।
Great.
एक
Sorry,
चीज
I
मेरे
apologize.
ब्रदर
मैं आपकी तरफ से न्यूरो न्यूरो अलग कर रहा था.
I
नहीं
was
नहीं,
about to say.
हमारा सही अच्छी बात है कि मेरे काम की नहीं होना चाहिए जिनका बल आते हैं हमारे पास भी पेशेंट, पर हम इतना स्ट्रेस नहीं देते हैं इस पे। हमेशा कार्डियोलॉजिस्ट ओपिनियन ही बोलते हैं कि आपको पहले कार्डियोलॉजिस्ट ओपिनियन देना है। वो ओके बोल देते हैं, उनकी तरफ से क्लियर हो गया तब हम आगे जाते हैं।
हम्म,
अदरवाइज हम अपनी तरफ से एमआरआई सीटी और ये सब कुछ नहीं कराते। मेरे ब्रदर को एक ये है कि जब वो बहुत तेज ठहाका लगा के हंसते हैं तब उनको कभी कभी चक्कर आ जाते हैं। तो इसका मुझे लगता है यही सिनकोप अटैक ही
Same,
है।
same.
इसके लिए
This
इसके
situational
लिए उन्होंने
syncope.
हैदराबाद में जाके बोला है कि कुछ मॉनिटर लगाना पड़ेगा आपको 6-7 दिन तक। पर
हम्म.
वो ब्रदर किसी तैयार नहीं हो रहे हैं मतलब लगवाने के लिए।
तो वो मॉनिटर
वो
जो है ये कार्डियक मॉनिटर है. एंड द थिंग इज कि ये मॉनिटर की यूटिलिटी तभी रहेगी जब
हम्म
उनको उस समय वो डिजीनेस हो रहा हो. तो या तो आप
हम्म
पहना के उनको खूब हंसाओ एंड देन सी
ठहाका
व्हाट
लगा,
इट इज
हाँ फिर
हैपनिंग.
करें, यस यस।
एंड यूजुअली हम
हम्म
लोग पहले ये मॉनिटर्स यूज करते थे 1 दिन के लिए, 2 दिन के लिए. दोज आर यूजलेस. सो इफ यू हैव टू यूज अ मॉनिटर, using it for anything less than 7 days, the yield is very low. So we usually use anything from 7 days to 30 days now. So
7 डेज के
24-hour
लिए बोला था
halter,
उनको।
48-hour halter is useless. So if you have to use it, I would give them 7 days. And there's not much into it. It's like आजकल तो बहुत, आई एम श्योर इंडिया में भी हैं, पैच मॉनिटर्स आ गए हैं. सो इट्स नॉट दैट बिग अ डील. इट्स नॉट इन्वेजिव, इट्स नथिंग. आई वुड से
हम्म
द थिंग इज कि डायग्नोसिस जरूरी है जस्ट टू बी गिविंग इट अ नेम. ट्रीटमेंट हमको मालूम है. इट्स लाइक यू जस्ट हैव टू चेंज बिहेवियर. कि अगर खूब हंसी आ रही, लाइक यू हैव टू हैव लाफ्टर इन योर वर्ल्ड. वो तो जिंदगी के लिए जरूरी है. बट देन maybe if you're standing up, sit down. The simple things like sitting down will overcome it. So उनको बोलो कि जैसे ही लगे बैठ
अच्छे से
जाओ.
बैठ गया।
बैठ जाओ
हम्म
और टांगे एक के ऊपर एक करके बैठ जाओ. or you just do a grip of this. The good thing about him
हम्म
is he's not passed out. So these are
हम्म
things that will be easily overcome क्योंकि उनको recurrent syncope नहीं है, खाली dizziness हो रहा है. So
हम्म
just simple thing would be enjoy life, laugh. May not be necessary to get a halter now, maybe later. Abhi just when you feel that way, just sit down and see how things go.
सर उनको देख के दूसरे लोग भी ठहाके लगा के हंसते रहेंगे, वो उस पोजीशन में देख के वो भी साथ में
I
ठहाके
know,
लगाएंगे.
I know.
दैट वाज वेरी क्यूट. और सर जो आपने बताया है कैरोटिड साइनस मसाज वाला,
हाँ जी.
तो दैट वन इज लाइक जस्ट clinical diagnosis,
Yeah.
right? Clinical.
So
There's no need for any imaging for that.
no, so the thing about that, there are some precautions of it. It's not that everybody should be careless with it or casual with it. is you need to be either hooked up to an ECG to see that pause when you're doing it.
Right, right,
Number two is you have to make sure those patients don't have carotid artery disease. So the first thing
right.
that you want to make sure is कि उनका सुनो, make sure there no bruise there. Make sure they've not had any history of stroke there.
So
Then,
we are going clinically, but like no
right.
imaging will show
No,
that.
no,
It's the
no.
clinical.
And avoid doing it on both sides together. एक
Mm,
side पे ही
mm,
करना. That is very important.
mm,
और हल्का
and-
करोगे ना तो कुछ नहीं होगा. To
mm,
have an effect, जोर से होना चाहिए. And it's not like it has to be a push in and rub rather than
mm.
just superficially. It has to be an impact कि सामने वाले को चोट लगे. So you have to start off with an apology saying, sorry, I'm going to hurt you for 10 seconds.
Yeah, that's a difficult one.
इसमें
And
कोई भी
then
डायरेक्शन में कर सकते हैं क्या?
हाँ सर.
कैरोटिड कोई भी डायरेक्शन में कर सकते हैं इसको?
Usually I do up ऊपर से नीचे तक and it's like pushing it
अच्छा.
in and then taking. It's like a stroke
हम्म.
but be connected to the monitor because
or an
there's
ECG just because that's how you will diagnose it, you know.
mm.
I
But
mean,
उस
even
समय
if you
यदि
think कि
syncope
चलो
हो गई तो they'll come back
you
during
three
doing the
seconds is
procedures.
other, and you normally, if you do it in supine position, you're not worried about it because
Okay.
the reality is most of above 3 seconds is considered positive. For somebody to have syncope with a pause, you need at least 6 seconds, and that too
Okay.
when you're standing up.
So
So
you'll
the
see it on the
likelihood,
monitor. They won't
yeah,
pass out.
yeah,
They won't really pass out.
yeah,
Okay, that makes
and
sense.
it's a controlled environment.
Hmm. Got it. And then I think what was multiple system atrophy? That was one thing I was in older.
It's like it's the combination of this is where neurology comes into play. It's like, you have the Scheidegger syndromes, those kind of scenarios, or those are the ones where you call multisystem atrophies.
All right. I think I had those were the most important questions for me. Neeta, would you like to ask anything?
I'm just gonna say hi, Adarsh sir.
नीता, I have to talk to you. तुम्हें कितने मैसेज किए, तुम कभी जवाब नहीं देती हो.
बापरे कभी ऐसा
चलो, we'll talk to you. We'll connect with you again.
yeah,
Hope
I
you're doing well.
say hi, and I want to say this. My first patient in Carroll, Iowa, was somebody who had been passing out for 20 years, and I did exactly that. Hooked it up to the machine and did carotid sinus. Though वहाँ पे छोटी जगह में, they insisted I had to take him to the ICU to do that. And diagnose किया उसको pacemaker लगा, and then I just became like the hero जो 20 साल से नहीं diagnose हुआ था.
Oh,
That's the fun part. That's the fun part,
I was
And
going to say that's clinician.
and then the second funny thing I want to say is there are times we all bring work home, and I do some of my transcriptions at home. So my husband, who's not a doctor, he knows syncope because I'm always dictating about syncope.
Great, great. So proud of him. Not
Yeah,
only you, but him also.
can be
That's a good one.
a bunch of things. And I just to say that it's been a long time.
Now we need to connect. I remember you fondly, and we talk about
Yeah,
you, but we
and
gotta connect.
our drive, famous was our drive to Chicago to go see for Natasha's birthday.
I know. So many good memories
Yeah.
from
All right,
chai and
Adarsh
from.
sir, I'm going to do Ghanti again. Thank you so
Okay.
much. This was a delight, and like someone already requested, we are going to have you come back. So before I just end, I wanted to try and share this what Sonu wrote on the screen so other people will be able to see it. Are you able to see it?
Yes.
Okay, so that's the write-up, and it will be part of the recording, and it ends in पिक्चर अभी बाकी है मेरे दोस्त. So thank you so much आदर्श सर. आपका इंट्रो से लेके टॉक और एंड तक बहुत ही अच्छा सेशन था.
No, thank you so much
We
for
all love
inviting
you a
me
lot.
and also connecting with so many old friends. So thank you for that too.
Thank you. And thank you, Kakani sir. That was our joy to have you join in?
Thank you. I listened intently. The recording stopped, right? Is that correct?
हाँ, आप कर रही हूँ मैं बंद. आप
Yeah.
बाइक से
So-
आप ऑफिस में आ गए, मैं बंद कर देती हूँ अब.